Welcome to our next Grand Rounds. So today we have with us Jessica Novrosky, right?
Yeah.
Sweet. Okay, she went to Radford University for her master's in speech and language pathology, and she's been working at St. Luke's for the past 4 years, and she sees patients at our 8th Avenue site. So today she's talking to us about concussion and cognitive therapy, which is a very important topic, especially during fall sports. Not that it's not during other times, but it happens more frequently now. And without further ado, Jessica.
Good morning. Thank you all for coming to Grand Rounds. I brought my grand around with me. Thought that joke would go well. So yeah,
we're here.
We're going to talk about concussion.
Oh, there I am. Okay. Oh wait, that's not me.
I hear someone talking.
Is that me? No, that's not me. Kind of looks like me, but her hair.
Someone didn't read them.
Yeah. That's perception. Got it. Okay. Why don't I see?
Can you guys mute your...
If I wave, maybe they'll wave back.
Amanda?
No.
Your...
No.
There you go. Now you're muted.
Okay. That would be distracting.
So thank you to everybody who is watching online as well.
Yes, hi, Etaf. Okay. All right, so as Steve said, I work at the outpatient physical therapy clinic at 8th Avenue in Bethlehem. Been there about 4 years, see a lot of different brain injuries, and concussions is one of the big ones right now, which is why we're going to talk about it. A little disclaimer for legal reasons. Okay. So what we're going to talk about today, this is the agenda. First, we're going to talk about evaluation. So when these patients come into me, we're going to talk about what kind of testing these concussion patients get from me, discuss whether cognitive therapy is warranted, whether they're in need for occupational therapy, speech therapy, or both. And we'll go into that a little bit more just because cognitive therapy is done by both of us. We're going to break down some assessment materials that I am familiar with. I have at 8th Avenue and just that I found helpful. Then we're going to talk about education, which is a really important piece of this project of concussion. A lot with just having these kids realize what they're going through, the parents, caregivers. So we're going to talk about some education materials and including accommodations. So that's something we do in our facility. If they are going back to school, we give them accommodation letters. So it's an easy transition when they're back into school. Then we're going to talk about some treatment and intervention that's done in our treatment sessions, what therapy looks like, talk about some activities that I do to target the goals. We're going to talk about maintenance. So getting towards the end of where we think they are, have they met their goals, or are they ready to get harder goals? And then last, we'll talk about how they are discharged. All right, so some things that hopefully by the end of this you will all know and learn are some course objectives. So we're going to design and individualize treatment plans for our post-concussion patients, identify those assessment tools to target that neurocognitive testing. We're going to talk about goals and then activities that can target those specific goals when it comes to cognitive therapy. We're going to talk about factors that contribute to the recovery time. Identify some techniques in goal writing. Again, talk about further cognitive testing with other disciplines. Since we are a multidisciplinary clinic, you know, the PTs, OTs, and speech, we all work together on getting these concussion patients back to where they were before, and then talk about discharge instructions. So first, what is a concussion? So this is a big hot topic right now, as you all know. Concussions, according to CDC, is a type of traumatic brain injury caused by a bump, blow, or jolt to the head or hit to the body that causes the head and brain to move rapidly back and forth. This sudden movement can cause the brain to bounce around or twist in the skull, creating chemical changes in the brain and sometimes stretching and damaging brain cells. A concussion does not always have to result in a loss of consciousness, which is why sometimes they can go undiagnosed. I did read that around in less than 10% of sports concussions, they actually do have a loss of consciousness. So it really is not always a determining factor whether they had a concussion or not. So when the concussion does happen, the neurons in the brain are damaged, causing this energy crisis, and the brain just, from there on, it needs to recover. So we see a lot of different symptoms after this happens, which we're going to talk about. So as I said, this is a growing public health concern, especially with sports right now, with a lot of the false stuff happening. Like Steve said, sports are the third leading cause of TBIs in young youths and adults. And it is said that 60% of high school students are participating in sports, and that will continue to grow. Some of the most common sports that we see, the post-concussion syndrome, are football and ice hockey. We do see it more in boys than girls. If you kind of link that with football and ice hockey, it kind of makes sense. And like I said, there's more interest than ever in concussions and trying to come up with protocols and how to get these kids back to where they were. So the physical symptoms that you're going to see right away with these concussions are the headaches, cervical or neck pain, nausea, dizziness, some issues with their balance, changes in sleep, and changes in their vision. So these are things right off the bat we can see. They can report it to us. This is something our physical therapy team is going to address when they come into the outpatient setting. So what I'm going to talk about is the cognitive portion of it, which is not really easily seen, as easy as the headaches and nausea and all of that. So when we talk about cognitive therapy in general, the goal of cognitive therapy is to get the person back to their highest independent functioning, to participate in their daily living, whether that's back at school, taking tests, or going back to work, being a manager, multitasking, all of those things. When we are conducting concussion therapy or cognitive therapy, what we're doing is we're capitalizing on strengths to address their weaknesses related to these functions that are affecting, could be their communication. We're facilitating the individual's activities and participation by assisting the person in acquiring new skills and strategies. So again, it's a lot of education on new ways to learn how to do things, and to help them compensate for what they may have lost. And then we're modifying any factors that may be affecting it. So we're looking at their environment, if it's too noisy, if they need to take a test in a different room, all those sorts of things. So I'm going to go over some just treatment approaches when it comes to speech and cognitive therapy in general. So there's a few on here. There's many more than this, but we're just going to talk about some of these. We have something called compensatory strategy training. So when we look at cognitive rehab, we kind of look at it from two ways. Are we restoring something that's been lost, or are we trying to compensate for what they have? So in this case, compensatory strategy training is we're just maximizing skills that they have, providing them with internal, external memory strategies or supports. Then when we talk about restorative therapy, we're going to do more of the rest of these, which there's something called computer-assisted treatment, which is when we use some sort of commercial software or apps to kind of guide us and provide additional therapy. So when you think of this, you kind of think of like Lumosity, or there's Brain HQ. On top of cognitive therapy, we talk about other ways individually at home they can really continue to work on their brain. Drill and practice training is something where we do repetitive drills, these cognitive tasks to practice new learning skills and try and stimulate the neural networks in their head to finally get the brain to regenerate and sort of form new pathways. Dual task training, this is more a higher level, so this is kind of when we talk about that multitasking things that sometimes with a brain injury you sort of lose the ability to do. So we're going to target trying to get them to do maybe a motor task while they're also doing a cognitive task. It's kind of like patting your head, rubbing your stomach, that kind of thing. Then we talk about errorless learning, which is a strategy or a treatment approach that we use where we really try and encourage the patient to get through an activity, not focusing on any errors. So we have to break it down into these small steps. We're providing them with models throughout the task, encouraging them to avoid any sort of guessing with the task that we're doing, correcting errors as they come up right then, and then slowly fading away our prompts so it's something they can do individually. And then metacognitive skills training has more to do about focusing on their awareness. So when they realize they might be doing something wrong, or they're losing their attention, it's getting them to identify their strategies on their own without us giving them those cues, because I'm not going to be following them around in school or at work to tell them, remember to use your strategies. So they have to start becoming more independent with that. So we talked about the physical symptoms that come with those concussions, and these are our cognitive and behavioral complaints that we're seeing post-concussion, which might not show up immediately, the first 5 to 10 days. Maybe they're just dealing with the pain, the headaches, all of that. This is what we see, and which is why they come and see us for outpatient therapy. So the left side is more of what our cognitive therapy is going to treat. So we're looking at difficulties with attention, concentration, memory, speed or thought processing, having judgment, executive planning, organization, insight, and word finding. Now, along with all this, it does come with a lot of behavioral problems such as depression, anxiety, impulsivity, and this, depending on the severity of this is something we always kind of screen for. We give them some education materials on it, make sure they know that this is something normal that happens. I mean, if you're getting headaches every day, it's kind of a bummer. If you're not back in school with your friends, you're going to get really upset and all this. So this is something we make sure we bring up to them, that they know it's normal. If we need to refer out to psych, we always do. But that is something that coincides with all of this. So as a speech-language pathologist, what is my job and what do I need to look for? So again, a lot of these kids come in with these initial physical symptoms. So a lot of times they could come through the door with a physical therapy script to work on return to play. But what I want to know, and what my PTs in my office know to look for, is to ask some of these questions. And we're going to go over a screening tool we use to help us to figure out if these kids have more going on than just headache and dizziness. So I'm looking for issues. Are they getting headaches after they're concentrating for a really long time? Is that what their headache's coming from? Are they having those problems with short and long-term memory? Are they complaining of difficulty with attention and with background noise? If they're out in the main gym, we play music, we got people doing all sorts of exercises. Are they having a hard time focusing on what their therapist is trying to tell them to do? Are they lacking that cognitive endurance? So that's sort of like, I can only do my homework for like 15 minutes and then I'm exhausted and need to take a nap, or they can't endure too much cognitive stimulation. Are they complaining that it's difficulty to think quickly, coming up with quick responses? Kids are always like, I used to be really witty, or I used to be able to tell jokes and talk with my friends, and now I kind of, with that slowed processing, I can't get my thoughts out quick enough. So they're frustrated with that. Are they complaining of difficulty with some organization, executive functioning, so just being able to juggle classes, school, all of that, back at work. So our barriers to recovery here are going to be that cognitive exertion, and then the triggering of symptoms. So when a patient comes in with these headaches, a lot of times if they're pretty severe and they're going to see all three therapists, so they come for PT, OT, and speech, is having PT, or what's giving them the headache? Is it the cognitive exercises? So in that case, a lot of times what we try and do is put a PT session in the middle. So they'll come in for their cognitive therapy with OT, maybe do some vision training, then do the PT, kind of give their eyes or brain a break. PT sometimes makes their headache better or worse depending on the patient and how they're doing. And then they would come to me for speech to do more cognitive therapy. So we want to look at all of those factors to see if that might help, depending, again, on where their headaches are coming from, whether it's more of the motion, the vision, or just cognitive thinking. Okay, so when they come in the door for their first day of evaluation, just some things that we always make sure we take. So we want to know when this concussion happened. Was there a loss of consciousness? Was there any rest time that they were given? And rest time is like doing nothing, being in the dark, sleeping, not on their phone, not on TV, anything. were they prescribed a certain amount of rest time, and did they do it? Have they had any prior concussions? This is a really big one, because this is going to have a lot to do sort of with prognosis and how we're going to make their treatment plan of care, because if this is, 4 or 5 concussions, we're dealing with a lot more here. And then either their prior or current level of education. So with our kiddos, we want to know what grade they're in, but also maybe, were they in honors classes? Did they need tutors before? And then with some of the adults we get, where did, high school degree, college degree, all of that. We're going to want to talk to them about their return to work or school plan. Have they returned yet? If not, are they planning to, with work, go back maybe light duty a couple of days a week and then generally go back, gradually, go back to full time? And then with the school plan, are any accommodations in place? If so, what are they? Or is that something that we're, as a team in our office, going to have to write up for them, give to their counselor so they know what accommodations they need? And then their current symptoms. So on day 1, we discussed the headache rating scale, which is that 1 to 10. Where's your headache? And that's something throughout day 1 to the last day. We're always kind of tracking before a session, after a session, even during a session, just, to keep track of where they are. And then if for some reason they come to me first, I would talk to them about if any PT or OT services are recommended. So this is a form that myself and an occupational therapist came up with a few years ago. That I sort of just recreated on the slide, but it's basically a sheet that concussion patients or any really brain injury patients get that come in our door, and we ask them to read through it and check off anything they're having a problem with. And it gives us a few different things. It lets us know, whether they're appropriate for speech, maybe OT, gives us an idea of their self-awareness. I always like to see who's filling it out. Is it the student? Is it mom? All of those things. So I sort of, in the parentheses, wrote kind of who's going to address it. So if there's a lot checked off in memory, that could really be our speech or occupational therapy teams, as well as attention. When we look more at processing and communication, those are flags for speech. Our emotional and sensitivity stuff is mostly done by our OTs. And then again, a lot of vision, again, OT. So this is something we also like to give on day 1 and the last day, or maybe like on re-eval, because again, it gives us a pretty good picture of what's going on and what they're reporting. Because a lot of times if you just ask, what are you having problems with, to a 14-year-old kid, you're not going to get all of these broken down. But if they see this and they think, oh, yeah, okay, I forgot, I can't do this. So we have found this very helpful, which if anybody wants a copy of it or to help them, I have it on my H drive. I can send it to you, but we like it. So continue with evaluation. Like I said, I was going to talk a little bit about testing. So these are some of the tests that I give and use in my clinic, mostly because, with me being in an outpatient setting, I have a whole hour to sit down with these patients, so I can do more of these comprehensive tests. These 2 at the bottom are more of those screening tools that we'll probably see more in inpatient settings, and our OTs always give the MOCA, so that's not something I give, but we all know how good of a tool that is. So I'll just talk about these first 4. The R-bands is an assessment of neuropsychological status. The reason I like this test is because it's aged from 12 to 89. So I can really give it across the board. And it does give me immediate memory, delayed memory, executive functioning, language, attention, sort of and vision. Everything across the board I'd want to see. Our TOL, this is more of a language test now. As you can see, it's only normed from 12 to 24, so this is really more of our student range. But if these kids come in and they're not really complaining of memory, but they're saying, I'm having a hard time formulating my words, or I have to write a paper and I have all these thoughts, but I can't get them into writing. This is really what that test is all about. So I'm going to be looking at their language, some editing, some sentence stuff, synonyms, antonyms, analogies. It's a really great test, so I like that one a lot. The CLQT, this is another good one, although it doesn't start till age 18. So that's something that's more for the adults. And this, again, is, this I've seen in inpatient too, because this is a pretty quick one to give, looking at language, attention, executive functioning, vision, all of that. And then the last one, so this RIPA is an information processing assessment, and this is a test where they don't look at anything. They listen to you the whole time and have to answer questions. There are 2 different versions of it. Not as higher level or hard to pass as the first one, but it is one that I do give every once in a while, so I threw that on there. Okay, so now that I did the evaluation, I'm going to grade their test, find out where they scale, you know, normal, mild, moderate, severe, and then recommend therapy. So for speech therapists, we like to use this term, cognitive linguistic therapy, kind of more for insurance reasons. But what I usually recommend is between 2 to 3 times a week and starting for 4 to 6 weeks, again, depending on the insurance. And then what we do is we reevaluate that patient after the first 4 to 6 weeks to determine if we're going to continue their plan of care. Okay, so once the patient is there, now we're going to talk about prognosis. So one of the things we educate on, so as I said earlier, education is a really big piece. We talk about this buzzword neuroplasticity, which is a great word, it's a great thing. It's our brain that can relearn and, you know, heal itself, and sort of the whole basis of cognitive therapy. So neuroplasticity is the brain's ability to reorganize itself, forming new neural connections throughout life. Neuroplasticity allows the neurons or nerve cells in the brain to compensate for an injury and disease, and to adjust activities in response to new situations or to changes in environment. So a lot of times with these concussion kids or adults, especially with like word finding. So for example, they come in and say, I keep getting tripped up on my words. I want to say something and I can't find the word. I try and explain this neuroplasticity using an analogy where I tell them, with a concussion or brain injury, you don't lose any of the words that you've learned. It's not like they're completely gone. It's just the access to those words have been blocked by having this concussion. So say you have a file cabinet, everything's ordered A to Z. When you want to find a word, you find it. It's easy, alphabetical. When you have a concussion or a brain injury, that shelf gets knocked over and everything's sort of spilled on the floor. So you have the word, it just takes you a really long time to find it through all those files. So it's kind of, and then I tell them basically what we're doing in therapy is we got to reorganize all of those files. We got to practice trying to pull those words. They're in there. It takes a little bit of time. We do these exercises and we're building new neural pathways. So hopefully everything gets organized again. So again, with neuroplasticity, our brain reorganization takes place in these axonal sprouting, which these undamaged neurons or axons can actually grow new nerve endings and reconnect. So again, I think this is really cool, and it's the whole basis of a lot of the recovery that we do. So an example below talks about if you have one hemisphere of the brain that's damaged, the intact hemisphere is going to take over some of its functions. We see this a lot in strokes. So the brain is just going to compensate for that damage by reorganizing and forming those new connections. And that is all stimulated through activity. So our brain is going to do a little bit of healing itself, but activity is all about therapy. Okay, so with education, this is also something that I created in-house as a handout for patients and caregivers. I have some of them with me today. This, and I have this broken up on another slide because I know it's really hard to read. Basically, this is what it looks like. And it's just concussion tips. So I want these kids or adults or caregivers to know the do's and don'ts of having a concussion, sort of broken down into layman's terms. So broken down here, we're going to talk about how now that they've had a concussion, you really need to protect yourself from having another concussion, especially by avoiding any contact sports right away until cleared by the doctor. Somebody who's had a concussion is at risk for what we call second impact syndrome. We encourage them to let others know that they've had a concussion, and maybe that's why they're not going to school or not participating in things or can't horse around by the pool, all of those things. We want to make sure they're following their medical provider's instructions and to be honest about their symptoms. A lot of these kids just want to go back to school, want to live a normal life, so they may not be super honest about their headache symptoms. So we really talk to them and try and get them to advocate for themselves as best as they can and let them know in the long run it's really going to make a difference. We encourage not to take any medications unless instructed by their medical provider. They want to limit activities that require intense concentration if that's something that gives them a headache. So playing video games or stuff on your phone, that's really going to give you a headache, or lower your attention. That's something you should probably take a break from. And then restricting from physical work, again, until cleared, because that can raise your blood pressure, putting you at further risk for injury and giving you those headaches. And then the rest of them talk about maximizing downtime and rest. If they're given a break from school, use it, just rest. Sleeping is key. Hopefully they can get sleep through the night. Not a lot of these patients can. And that's one of the things they complain to their doctors about. They're waking up a lot, or they're waking up with a headache. Why am I waking up with a headache? I didn't do anything. But they need to know sometimes, these headaches are a primary sign of exhaustion. So maybe they need to look back and, did I push it too much? Did I stay up too late? They need to listen to their headaches to try and limit severity by resting. Drinking plenty of water, avoiding alcohol, drug use, sort of obvious things to us, but it's a great thing to put in there just to, encourage healthy lifestyle. If they are suffering from any sort of light sensitivities, wearing a sunglasses or hat to compensate. Again, if they're an OT, they'll talk a lot more about other strategies, different sunglasses that help, blue blockers, things like that. And then if they have any noise sensitivities, wearing earplugs if needed. This last education one, so this is another thing I made up. And this I use with patients who I feel like don't realize the severity, or I feel like they need to be more, be more of an advocate for themselves or realize what's going on. And what I tell them to do, so we're going through all these symptoms that we talked about, physical symptoms, some cognitive symptoms, some behavioral. And what I say is I want you to maybe do this once a day, in the beginning of the day, the end of the day. Tell me first what your headache, if you woke up with a headache, what was it? Did you wake up with any of these symptoms, and were they mild, moderate, or severe? If they can fill this out in the first few weeks of their recovery, kind of gives them an idea of, wow, look where I came from. If we pull the ones from the beginning, or I look at it and I say, okay, I see your fatigue was severe on this day. Like, did they write any notes, or let's talk about what made it like that. So again, just another piece of the puzzle to help us get through all of these things. Okay, so I talked about accommodations earlier, and this is something that is written in our office by the speech therapist or occupational therapist, where basically we're going to list their limitations. So we're going to use that concussion checklist I showed you earlier, where they check off like attention, memory, all of that, having problems with. And then we're going to provide some examples or provide some accommodations to the school of what we think they need at this time. So some examples would be, requesting take-home testing, requesting multiple choice testing. These patients, may not be able or may need extra time, with memory. They do better with multiple choice. So this is something right now that's going to have to help them ease their way back into school. We put things in like leaving early or having late transitions between classrooms, so they're avoiding the crowds of, changing from class to class, if that's something that sort of is overwhelming for them. Eating lunch in a quiet space to decrease auditory stimulation. Again, we want to prevent headaches throughout the day. Allowing the students to keep their books in the class, so that's one less thing they have to do, go back to their locker or carry a heavy book bag, which is going to pull on their neck, and then they're going to get a headache. Asking if they sit in front of the class to decrease any stimulation from watching other kids or staring out the window or anything like that. And then providing written notes. So, for example, if one of them came to my lecture today, giving them my slides and having them follow along and having something written, so it kind of keeps their attention during a presentation like this. So those are just some examples of things that we try and help these kids out with. Usually it's sent to the guidance counselor, and we facilitate through mom or dad, making sure these are being followed through with. All right, so now we talk about intervention and treatment. So a speech therapy session, what does it look like? So first we're going to decide our best treatment approach. So I went over some of those earlier, whether it's the drill and practice, the errorless learning, a little bit of everything. So I'm going to pull some activities. I'm going to track their symptoms throughout the session, and that's that 1 to 10 scale. For headaches, sometimes I ask them if they have nausea, put that on a 1 to 10 scale. Always putting that in the note, so from session to session I kind of know where we are with headaches, nausea, all of that. Allowing brain rest is a big one. So if we're doing an activity and I can really see that they're having a hard time, have them take a break, a physical break. They can walk around the clinic, go to get a drink of water, go to the bathroom. I don't want them just sitting there looking at their phone while they say, here, take a little break, because that's not really a break. But providing breaks as needed throughout an hour session is going to help us get through that hour session. A lot of times I like to provide auditory tasks to decrease visual stimuli, especially if that's something that they're symptomatic with. So if any sort of visual tasks are giving them a headache because they're having either that convergence issue or sensitivity, I'm going to do a lot of tasks where they have to listen to me and answer questions and don't have to do a worksheet or something like that. And then room accommodations. So in my office, in our clinic on 8th Avenue, speech therapy has their own treatment rooms. So we do have a door we can close. I have blackout shades, and I can also turn out the lights if needed. So those are all sorts of things that I can do to accommodate, but I can also back off on to slowly get them back to real life setting. So I can open the door and they can hear all the craziness going on outside if I really want to focus on that attention. But it is nice for us to have the private treatment rooms. Okay, so here's some goals, for example, that we use in cognitive therapy. So word finding is a big one. So an example here would be the patient will complete word generation tasks, for example, analogies or category matrices, with 80% accuracy using word finding strategies to facilitate improved word retrieval skills. We also have one about naming an average of 15 items in a category in 60 seconds over 5 trials. We had a lot of time this morning. I would really like to do all of these with you because it's pretty fun. Or I think it's fun. But I'll show you some activities afterwards that are going to target these. We have some goals for memory. So we're going to identify some main ideas, some supporting details. If I read them a paragraph or story, I want them to sort of paraphrase it back to me. Are they getting all the details? Why or why not? This could be something that can be given auditorily again, or if they can read it and then answer questions. And then thought organization. So this has a little bit more to do with that processing that I talked about. If things are kind of slowed, we do things such as mental manipulation tasks to target working memory in an activity called ANAGRAMS. So I'm going to show you that in a couple slides and what that's all about and what that makes them do. And then goals for attention. So we'll do auditory attention processing tasks, which again I'll show you in a couple slides from now, but that's sort of works on a lot of things, memory and processing. Okay, so this is the fun stuff. This is a word finding activity called a category matrices. So what they're going to do here, this is something they can do either I can ask them or it's on a worksheet and they can fill it out. But the category is up top, so numbers. So what they need to do is find a number that starts with the letter F and a letter that starts with M, O, and S. So for example, a number that starts with F is 5. M could be million. O could be, Amy? 1. People always miss that one. S could be 6. Good. Yeah, so it's just going through something like this, seeing how many they can do on their own. You know, if they can't think of any, I'm giving them clues, things like that. But again, that's a fun one. Okay, so this is anagrams. This one I really love because a lot of times I do it as an auditory task to focus on their attention and mental manipulation. So you're given a word, and you have to listen to it. They don't get this. They don't see this at all. So I say, I want you to think of the word late. How can you rearrange the letters in the word late to make a new word? So they have to think about L-A-T-E. Okay, how do I rearrange that? I can make the word tail. So this can be pretty challenging because, again, they have to think about it. They can't write it down and find that new word. So let's think. Shelby. Where are you, Shelby? Yeah, it's a shame that you know me because I'll call you out. Let's see. Can you think race? Do you know what word that could be? Care. I said Shelby. I really wanted to embarrass her.
Oh, sorry.
Yeah, so something like this, again, sort of that auditory task. If they really can't get it, I'll let them write it down. But I find this pretty challenging, and sometimes it gives them a headache because they're really, really concentrating on remembering how to spell it, what the words are, all of that. The other mental manipulation activity I was talking about was sort of a sequential task. So what I would do for these examples, these are a series of 4 or 5 words. So what I do is I would read these out loud, and I say, repeat them back to me in reverse order. So they have to remember the 4, then repeat them back in reverse. We could do the same sort of task, but alphabetically. Oh, there should be a comma right there, sorry. We could do it sequentially with words like months, days, things like that, by size, or it's just a scrambled sentence. So I'm giving them a sentence that's scrambled up. They have to listen to it and then rearrange it. So again, just fun speech therapy things. Okay, so this looks really scary, but this is also a task that we do, which is more complex, used for information processing, something called math coding. And what you do, now sometimes I just have them do this, but a lot of times I'll have them do this and something else, like they're filling this out and I'm also asking them questions about a story. So this is for the high level kids. But basically, so if you can see that up there, it says start with number 4. Essentially, it's a really big math problem, and at the end, they're going to have a solution. You start with the number 4, and then you look at this symbol in between the 2 dots. You got to use the key down here. Can't really see it, but the hashtag means subtract 3. So you go from 4 to 1, and then the next symbol is a dotted straight line. So from 1, dotted straight line means add 2, you get 3. So you have to kind of keep your attention, snake all the way down, end up with an answer. Can be pretty tricky, especially when they throw in these double symbols. So this one here is a dotted curved line and an @ symbol. So it's a lot of visual attention. And again, I might be asking them while they're doing this to go through the alphabet and give me like an animal for every letter. You know, A is alligator, B is, you know, bear, while they're also doing math. So people don't like this one. So speaking of really fun that we have in therapy, so here are some games you guys might be familiar with. These are like all games I find at Target or Barnes & Noble, but target a lot of things for speech therapy and cognitive linguistic therapy. So the first one is Taboo. If you guys remember this at all, that is where you get a card and you have to describe a word such as like shrimp, but you're not allowed to say seafood, you're not allowed to say you know, Bubba Gump, you're not allowed to, like, there's all these words you can't say. So it targets what we call circumlocution, which is sort of talking, giving semantic details around a word to kind of get to the key word. So that is a game we use a lot for word finding. Another game, Scattergory, so that's where you get a card of things you have to name, like a boy's name, a city, a famous athlete, but you roll the dice and you end on a letter. So like all your answers have to start with S. So that kind of targets more of a generative naming, kind of narrows it down. 6-word memoir targets semantic fluency and descriptive skills. So this is where you're given a word like, I don't know, gasoline, and you only have 6 words to describe it to me, and you can't go over those 6 words. So you can use it as a sentence, you know, fill up my car with this gasoline, or, you know, fuel, diesel, unleaded, you know, stuff like that. So just naming stuff. Anomia is a card game. Anomia is actually a speech word. It's a diagnosis that means having trouble with naming. So obviously I bought that game, and that is targeting word finding. So I use it. Well, all these games are meant to be played in a group, but for the purpose of this game, when I use it with patients, I use it as like a speed naming task. So there's a bunch of cards that you have to name a crustacean, name a TV show, name a 90s band, name whatever. So it's sort of a rapid naming task that they have to pull all these words from, and I usually see how many they can do in a minute, and then try another time. Again, just increasing that speed of processing. Pathwords is a visual spatial word finding task, and it's kind of like a crossword puzzle. You got to find words using these blocks. It's pretty visual though, but that's a higher level one. And then blink is attention. There's no words or language in this one, but it's divided attention, visual attention, and it's kind of about matching across the board. And again, I look a lot at speed. Just as, it's a new learning task, but then across the board, across how many sessions could they improve their accuracy with that? Those are some games. Okay, so now that we've done some therapy, we're going to take a look at maintenance. So we're going to reassess the patients to determine whether they're going to continue to need cognitive therapy or not, go over their goals, talk about accommodations. Do they still need them? Have they been lifted? Any restrictions that have been lifted at work or school, including going back to testing, going back to sports, all of that. However, just because they went back to sports does not necessarily mean that they're done with cognitive therapy. Sometimes these kids can bounce back physically, but not always mentally. So they could still be seeing us when they do go back to playing sports. And then, kind of like I said earlier, is it time for me to add any external factors to our treatment sessions, such as opening the door, limiting the breaks, or giving them some more of those multitasking or divided attention tasks to up the ante. Then we're going to talk about discharge. So if they're ready for discharge, we're going to continue to talk to them about symptom management, if they still are having symptoms, advocating for themselves, making sure they don't get another concussion, come back. If they are can they demonstrate use of strategies throughout treatment sessions and in school? Talk to them about that concussion prevention because they are at a greater risk now. And then, assuming by then, hopefully they have been cleared by their doctor. I threw this slide in there just for any SLPs in the room. This is just some billing things that we do as far as insurance coverage. Cognitive therapy is one of those things where there's not a ton of evidence-based practices or data out there, so insurances can be difficult. These eval codes are usually what we use depending on our testing. We have a cognitive testing code, which could be used for like that CLQT or R bands. This code's great because we can bill for documentation, but if we're doing more of a language task like the toll, we have to use the speech language comprehension code, and then we're always using the same treatment code. I haven't had a ton of bounce back from insurances. I know OT has, but again, it's kind of all in the coding, the wording. Cognitive linguistic therapy, language is a big buzzword that we make sure we use because it's not just memory therapy. Okay, so at the end here I threw in some research that I found that has to do with concussions or traumatic brain injuries. This first one talks about that discharge instruction, so that's sort of why we talked a lot today about why education is key for a lot of these patients. So this test looked at giving concussion patients a specific booklet on concussions and symptoms and self-management versus just traditional discharge paperwork, and sort of found that participants really liked having the information and how to go back to normal activities and found it a good resource. It was a small size of a sample size, but I thought it was a good piece that I'd like to continue to incorporate in the outpatient setting. So that is a study on discharge instructions. This one talked about assessment and treatment of cognition and communication skills in adults with brain injuries using telepractice. That is not something that I do, but so telepractice is kind of like Skype therapy essentially, which could be the future. But right now, according to this research, shocker, continued research is needed. So not a ton of information was found off of this test. It was kind of interesting just to see, the kinds of cognitive communication, activities they did or testings they gave. But as far as review of this, nothing really huge came out of it, fortunately. Group therapy and outcomes for inpatient rehab after TBI. So this was a pretty big study that looked at TBI patients doing group therapy versus individual therapy. This was among all PT, OT, and speech. The results were non-significant for group versus individual. Personally, I only do individual therapy in my treatment sessions. I think group is a good idea. I think it depends on the patient. And I think there's a lot of hoops you have to jump through when it comes with insurances and billing. So that's probably why it's not a huge thing right now. This study looked at athletes coming out of Miami University and talked about concussion. This was more of a case study, so it just looked at 2 adults here. One of them who had no previous concussions, one who did. And basically, with the case 1, the testing captured changes in visual scanning, mental flexibility, word fluency, retrieval, auditory memory, and they had returned to baseline at 10 days post-injury. And the case 2, who had the prior concussions, was more challenging and had symptoms beyond a 10-day period. And that's really why it's important for us to know if they've had previous concussions, because a lot of times we're looking at a longer recovery time. Then the interdisciplinary team for this one was really important, which is again something we are very proud of at 8th Avenue, all of our PT, OT, and speeches who work together to help these patients. And then the last study here talked about managing persistent cognitive symptoms after these sports concussions. So these are going to be most of my patients, because by the time they get to me, it's already been like a week or so since their concussion, so we're going to call that persistent. So this looked at some of those treatment options that we were discussing, the metacognitive, the assistive technology, all of that. And the great thing was a lot of them met their goals. So this is a great study showing cognitive therapy is helpful for these patients. But again, encouraging more studies to be done to help that population. So from the beginning, we talked about things that hopefully I taught you about cognitive therapy and concussion. So designing the treatment plans, pulling some assessment tools, looking at some fun activities that we do that target those goals, those factors that contribute to getting them to recover, goals, multidisciplinary approaches, and discharge instructions. Yay, thank you for coming. Any questions? Yeah.
When you have younger children, what tests do you guys use? That seems to be the biggest challenge. Really young, like under 12.
I'm not getting them if they're younger 12. Not at my office, no.
I don't know you guys. Probably yourself. So common intuition.
Yeah. 12 is probably the youngest I've gotten, and that.
For the people who are listening, can you repeat what you said?
Sorry.
Her question.
Question was, kiddos younger than 12, what testing do we give? I don't see kids that young, but Amy Taylor said usually the SELF, which is a language functioning test, is normed for those kids. If they're 12 or older, I give the R-bands. Any other questions? Yes.
Just in your experience, has there been any prognostic indicators or factors that have shown an increased recovery speed versus a delayed recovery speed?
So the question is, in my experience, has there been any factors that determine their recovery speed, whether slower or faster? Definitely the advocating for themselves and taking breaks when they know they need it, rather pushing through it. Following our treatment plan, I give homework at every session, and my patients that go home and do it do a lot better because they're only with me for an hour twice a week. So that's not, and if they're not in school or challenged in school, that's really what's going to get them to come back. Age is a big one. So the students bounce back versus my 40 and up motor vehicle accidents is a big one too. Not to say that they don't get better, but unfortunately we know, age is always a factor. And then again, just kind of pre-morbid stuff with other diagnosis, or if they had ADHD beforehand, I'm not looking to get them heal their ADHD, but I need to know that to kind of give myself realistic goals. Yeah.
Thank you.
Mm-hmm.
We sometimes have patients who will be transferred over from different areas like Anderson, but when we recommend outpatient therapy, we know that what we were told prior is that 8th Avenue is where the majority of this post-concussive therapy happens. Is that still the case, or are there other outpatient clinics that have all OTPT speech who could address these patients?
Sure. So question was asking about OTPT and speech for cognitive therapy outside of the 8th Avenue Clinic in Bethlehem when you get people from all over. Our Tillman office in Allentown has all 3 disciplines and treats concussions. And that's about it.
Hillcrest, New Jersey.
Hillcrest, New Jersey also treats those things. PTOT and speech. Thank you.
How far, after injury, do you feel like you're getting patients from the hospital? Do you know, how long it's taken them to get to?
Question was if I know how long it takes the patient to get to me after they get out of the hospital. Mm-hmm. A lot of time. I mean, if it's an epic, I can see it. Usually right after, I'd say ASAP. From discharge, if they follow through, and I think one of the great things that is helping us is having the work queue of those orders that do go in, because if they're not advocating for themselves and calling right away for a speech therapy eval, we're calling them and saying, hey, come in for speech. So that's been helpful, getting them sooner. Mm-hmm. Yep.
With that trauma, sometimes there's a PTSD component associated with it. Are the cognitive intervention strategies tailored differently for those patients?
Sure. So question was patients with cognitive or concussions who often suffer from PTSD after a concussion, if we talk about strategies and if our therapy addresses that at all. So from a speech therapy point of view, my expertise and knowledge is more limited in that aspect. A lot of times our occupational therapists are more trained and have materials to address some of the behavioral and emotional aspects that come along with it. So we usually start them with that in our office. And then again, if we feel it's out of our realm, we're going to look for other sources. But I mean, on definitely the higher level of the brain injury, especially TBI, suicide prevention and risk has been something in our office that we've had to deal with, take very seriously. It's pretty scary, but we usually have a good way to refer out and make sure we're giving the patient what they need. So, yeah.
You talked about some of the treatments through Skype, like the tele.
Yeah.
What were that was all for concussion?
Yeah.
Returns?
Yeah, I believe so.
And what were you said that they showed some positive results, but it was hard to see exactly what was the number, what specific interventions worked.
I honestly don't remember just because I did this so long ago as far as the activities and strategies they used over. And usually when they talk about it, it's pretty broad, not super specific as far as some of the stuff I talked about today. It's more of we're doing, memory stuff, answering questions. With that kind of practice, I think it's hard because as far as materials go, are they sending things through email and they're filling it out and all of that? Again, this one was pretty vague, so sorry, that wasn't a really great answer. But I'd have to find that article again. Anything else? Cool. Thank you for coming.
For New Jersey people, make sure you sign out and make sure you definitely sign in. Yes?
And anybody that needs to ask for information about college, let me know.
Thank you for joining us online.